Thank you very much, everybody. Thank you very much for inviting us to come and talk to you. I'm Jonathan Pollock. I'm one of the plastic and reconstructive surgeons working in Nottingham. And the focus of my practice is head and neck reconstruction and head and neck skin cancer. Tamimi is one of my plastic surgery colleagues who similarly works in the head and neck reconstructive department with myself. So we were asked to talk about really predominantly around pre-operative management of head and neck patients, and a few specific points that we were asked to focus on. So this is the unit that we work in. The Queen's Medical Centre in Nottingham is where our major head and neck cancer work is done. It's a large teaching hospital, very busy place to work, and the head and neck workload is split between plastic surgery, ENT, and the maxillofacial surgery department. The main focus of our reconstructive work is with anything that's come from the skin cancer, but also any of the ENT reconstructive workload, which will be oropharynx, pharyngeal recon, and the temporal bone reconstruction. And it's mainly my colleagues in maxillofacial surgery who'll do more of the oral cavity and bony reconstruction. But we'll touch a bit on both as we go through our presentation. So what we were asked to talk about was firstly about patient selection for preoperative considerations for head and neck reconstructive patients, a bit about the indications or contraindications for free flaps and pedicled flaps, although that will obviously be covered a little bit in some of the other talks, so I won't go over that in too much detail. I'm then going to hand over to Sarmad, who's going to talk about preoperative imaging, both of the donor site and the recipient site. And also cover the one topic we were asked to talk about, which is are pedicled flaps truly safer? So to start off with the patient selection in our unit, as I'm sure in many of the units around the world, we have an MDT discussion. And really the focus of all of this has to begin with the cancer treatment. And we have to agree as an MDT that surgery is the best modality of treatment for that histology, for the site, for the stage of the cancer. And that really is where all of our decision making would begin from. And once the MDT are happy that surgery is the best modality of treatment, obviously as part of our staging, we'd want to look at the presence or absence of distant metastases, although we wouldn't regard that as an absolute contraindication to the use of surgery, because certainly patients with oligometastatic or single metastatic disease would be considered for aggressive treatment of those metastases through either surgical resection or SABR. And there are a number of papers around the world, one from Germany a couple of years ago, that showed out of their 46 patients with distant metastases at the point of presentation, they were able to get 3 or 4 long-term survivors through aggressive management of those patients through surgical resection. But I think the vast majority of patients who have distant metastases would tend to be treated with palliative chemotherapy. When we're then deciding that surgery appears to be the best modality of treatment for histology, site and stage, and we've ruled out distant metastases or feel those can be treated aggressively with the aim of cure, we then obviously want to look at whether the patient's fit enough to undergo surgery. And the majority of patients we'd be treating would have a performance status of 0 to 1, although actually there are a fair number of patients in whom we've operated on them with a performance status of 2. But one of the things that we feel quite strongly is that age isn't a bar. It's not a bar to surgical treatment, and it certainly isn't a bar to any reconstructive planning or free flaps. And there's a number of good papers out there that show excellent survival of free flaps, even in elderly patients. I've made an additional point there about the option of treatment for cure or palliation. And again, I think that whilst it is not something we would do commonly, there are still circumstances in the head and neck where actually it's quite legitimate to offer a patient a major resection and potentially a significant reconstruction with the view of palliating symptoms. But again, I wouldn't say that's something that we would do on a very regular basis. I think what we felt about the patient selection topic itself of who do you operate on and who do you not, is that we don't really ever feel that reconstruction drives the modality of treatment. And we couldn't think of a case where our head and neck colleagues felt that the tumour was resectable, and we said, well, actually, the reconstruction is such a challenge that we think they should have a different modality of treatment, and they should be pushed into radiotherapy. That really, if our surgical colleagues feel they can resect it, achieve clear margins with the view of cure, there would always be some form of reconstruction that we could offer that patient that wouldn't drive them into a different modality of treatment. So Then looking specifically at this issue of indications for free flaps or pedicled flaps and contraindications, and how we look at that preoperative decision making. I mean, first of all, our unit's approach, again, as I suspect is the case in many units around the world, is that we would opt for a free flap above everything else. We feel that that provides us with the greatest flexibility. It provides us with the best outcomes that we'll go on to in a little bit more detail later on in the talk. But that really is our predominant starting point. And if we look at the overall number of cases we do, Sarmad and I have looked at the cases we've done over the last 2 or 3 years, and really our numbers of non-free flap reconstruction for major defects is under 10%. And we'll talk a bit about the reasons why we have done pedicled flaps and what's been the driver for that. We felt when we discussed it that there was no technical contraindication to free tissue transfer, that actually there wasn't anything that would drive us absolutely into doing a pedicled flap. The only example we could think of is we have some cases with very low pharyngeal tumours heading into the upper esophagus, where once it gets to a certain level into the thorax, we can't physically reach it to inset a free flap at that level. And under those circumstances, the patient will be more likely to have a gastric pull-up with our thoracic and upper GI colleagues. But other than that, really, we felt that there was always a situation where you can do a free flap over a pedicled flap. We did think it's quite important to look at the types and extent of tissue reconstruction and how that can influence the decision-making between free flap and pedicled flap. Because our feeling was very much that the reach of pedicled flaps and the kind of functional results you can get as you head more superiorly into the oral cavity are really so poor that it would be vanishingly rare that we would ever contemplate putting a pedicled flap in for those patients. Whereas the lower down within the upper airway digestive tract, you can get comparable, if not as good results. But the other big driver for that will, I'll pull up the slide now that shows that. So in the UK, we did an analysis of just shy of 12,000 head and neck reconstructive patients over about a 10-year period from every unit in the country. And one of the things that came out of that paper is that if you look at different sites of reconstruction, so on the left-hand side of the graph is skull base or facial resections, salivary gland, and oral glossectomy, maxillectomy patients. And towards the right-hand side is things that are much closer to neck vessels, viscera, and the airway, so oropharyngeal and pharyngolaryngeal. And what this graph shows is that if you lose a free flap, so you have a failed reconstruction of any kind, in the skull base, the face, the salivary gland, it has little to no impact on your rate of in-hospital death. So the odds ratio remains essentially 1. Whereas once you move towards oropharyngeal and pharyngolaryngeal resection and reconstruction, your odds ratio of in-hospital death quadruples if you lose your flap. Now, the reason why Sarmad and I think that's important is it means that if you have a concern that you might lose a flap, be it in the situation of primary surgery with adverse patient characteristics, or in a setting of salvage or redo surgery after a failed flap, that if we're on the left-hand side of that graph, we feel very confident to use a free flap again or to use a free flap as our primary treatment. Once we move towards the right-hand side of that graph, you have to remember that really all of this work is for the purposes of the patient surviving, and that survival has to be above everything else. It's no good doing a wonderful reconstruction if the patient doesn't survive. And so we would want to do the most robust and solid reconstruction that we can under the circumstances. So that may well, under certain patient circumstances, be a pedicled flap. So yeah, so the green circle is your safe side, where your odds ratio of dying in hospital is exactly the same whether your flap survives or not. The right-hand side is where your odds ratio quadruples. So we then move on to, so there's no absolute contraindications. So what are the soft relative contraindications that we bring into our decision-making? So poor physical or mental health of the patient, we think, is something that we would take into account. If the patient has significant hemodynamic instability that might compromise microvascular patency after surgery, we would think about that. But again, we're very lucky to have excellent anaesthetists like Dr. Norris, who can keep our patients pretty rock steady through surgery. And for most of the patients, if they're fit enough to get through a major head and neck resection, then they're fit enough to have a free flap. But we would take that into account. However, what we have had is patients with significant mental health instability, where one of our concerns would be if we plumb the flap in and it's slightly positional to begin with. So for whatever reason, the pedicle position is such that if the patient was to flail around too much, it might compromise the flap survival. That's something that would come into our decision making of how well do we think the patient's going to cope afterwards. Are they going to follow our perioperative and post-operative instructions? So that will be brought into our decision making. Peripheral vascular disease, we think, is something that either peripheral vascular disease as a history, particularly if patients have had to have invasive surgery for that. So femoral endarterectomies, bypass surgery, that certainly influences the donor site that you would be looking at. And it might make you start to bring that into your decision making about whether a free flap would be the first option for you. Then the surgical resection elements of it. So has the patient had a neck dissection before and we're going back into an old neck? Have they had previous radiotherapy? The paper that's quoted there is a single paper from a single surgeon in Japan, where he felt in his series he'd gotten up to 25% risk of flap failure in an irradiated neck. I have to say that's not something that we replicate in our series, but it does show that there are units out there that find that going back in and doing microsurgery in an irradiated neck is of a concern. For us, most of those issues, previous neck dissections, previous reconstruction, previous radiotherapy, wouldn't stop us from performing free flap surgery. What we would think about is if there's carotid involvement, particularly if it's bilateral carotid involvement, because if the patient has got very little in the way of external carotid branches for you to plumb into, having to go into the transverse cervical or bring vein loops from the internal mammaries, we think it's very reasonable to do if you're looking at oral cavity or salivary gland facial reconstruction. But once you're looking at it for a pharyngeal reconstruction where flap survival does relate to patient survival, we felt that was somewhere where we might move more towards a pedicled flap. Then some of the other things we'd think about, double flap required. Again, if we've got a laryngeal tumour that's come out of the skin and gone into the pharynx, there have been occasions where we'd use one flap to line the pharyngeal mucosa and another flap for the skin, where again we may opt for a pedicled and a free combined rather than two free. But again, we wouldn't rule out a double free flap if required. And the last 2 points we put on there is about theatre space availability. So particularly with pharyngeal reconstruction, we, both Sarmad and myself, feel quite strongly that if a flap is struggling and it needs to go back to theatre, we don't want to leave them without a reconstruction for a prolonged period of time because of the risk of them developing erosion of the neck vessels, mediastinitis, etc. We want to go in and give them some form of reconstruction as soon as we can. Now, in our unit, out of hours, we'd be taking them back to the general emergency theatres to do that, where we don't have microsurgically trained staff. Theatre time is at a premium, and it may therefore be under those circumstances we want a robust flap that we can do in a relatively short space of time. And so under those circumstances, yeah, we might go for a pedicled flap over a free, but ultimately the free flap will be our go-to above everything else. So I'll hand over to Sarmad now, who'll cover some of the imaging workup side of things.
So yeah, as once we have decided to go for a free flap, as in most of the head and neck cases, our first go-to as option would be, as Jonathan said, would be a free flap reconstruction. Then there's always a discussion amongst plastic surgeons whether we need any imaging workup purely to see the vascularity. And we are talking about vascularity of two areas, the donor site vascularity and the recipient site vascularity. In general, our protocol in our unit is that we, for anterolateral thigh flaps or MSAP flap, all we are going to do is to use handheld Doppler. We do not specifically go for any specific imaging to look for any perforators, or and we will rely on handheld Doppler for that. In case of radial forearm, it's just examination, doing Allen's test. And if we are satisfied with that, we again wouldn't go for any specific imaging for that. When it comes to free fibula, bony scapula, and DCIA, as Jonathan has mentioned, that most of that work is being done by our maxillofacial colleagues over here. They would be doing imaging for all of the bony reconstructions, not only to look for any vascular problems if they can pick anything up, but primarily they would be doing it in all the cases nowadays to plan the osteotomies. So while they're doing it, giving in a contrast and having a look at the blood vessels, and if they pick up any anomalies, so they would be doing that regularly. So that's what we are doing in our center. Generally, when we talk about imaging workup for the donor side, there are two considerations in my mind. One is whether we want to look at the vessel runoff, especially when we talk about free fibula, if all the three vessels in the leg are patent or not, and if the leg or the foot is being supplied predominantly by the peroneal system, and if you compromise the peroneal system or take the free fibula on that, would that compromise the circulation to the rest of the leg? And there have been reported incidents of these anomalies as well. And the other question is whether you want to do any imaging to do any perforated assessment or not. So coming to indications for the donor side imaging in general, something that I would consider when we look at our patients is that if the patient has got any past history of any injury to the fibula, so in case of a free fibula, we would be probably looking at doing some imaging for that patient. In case of anterolateral thigh flap or a groin flap, if the patient has had previous groin dissection or any previous tumor surgery to the groin, that is again an area where we may like to assess the main vessels in that area. Similarly, coming to the scapular or latissimus dorsi flap, if the patient has any axillary dissection previously, and unless it has been documented that these vessels have been preserved, that is again an area where you might like to do some imaging beforehand. Similarly, it's quite obvious that if you are going to take a skin pedal from an area and there are some obvious injuries in that area, you might like to consider doing some imaging workup. Recently, we had one of our patients who had been abusing drugs for quite a few years, and she needed pharyngeal reconstruction. Our go-to flap for pharyngeal reconstruction is anterolateral thigh flap. But when we looked at her thighs were studded with stab and marks and marks of needle marks, and we could see superficial thrombophlebitis and all that. So that is sort of a case where we might think that, okay, this is a case where I would like to have a better idea of how the vessels in the leg are working before I start raising that flap up. In addition to past history, if on clinical examination, if there is any evidence of peripheral vascular disease, if the patient turns out to be hypertensive, and if we are going to go for lower limb flaps, again, that might be a consideration of doing an imaging workup for that patient. Then coming to what sort of imaging would you do? So there are different people in different units who are doing MRA, CT angiogram, simple angiogram, or color flow Doppler. So it depends upon primarily the availability of whatever you've got in your setup. We've got the advantage of having excellent radiologists with us who work with us for other free flaps, perforative flaps as well, and they are quite keen to do MRAs for our patients so that we can assess distal runoff, or if we want to look at the perforators as well. In terms of what's the benefit of doing any of these angiograms, so this is a paper from Wang, in which they looked at quite a number of cases, more than 100 cases, who were going free fibula reconstruction. And they compared various imaging modalities like color flow Doppler, angiogram, CT angiogram, and MR angiogram in those cases. And as you can see on the right, so the abnormalities that were picked up were about 55% in angiogram and CT angiogram as well. However, the pickup rate of any abnormalities by color for Doppler was significantly lower as compared to any of the other modalities. Another important point to see here is that the abnormality altered the surgical plan in almost half of the patients, so around 42% of patients. So I think that just indicates that if you're going to go for free fibula, it might be something that you would like to do in routine in order to assess the vascularity. And as I said before, that if you're going to do any imaging to plan your osteotomies, it would be beneficial to have a look at the blood vessels as well, so that, if you want to choose which leg to go for, which would be better perfused and which won't be compromising distal blood supply to the foot, so you may like to choose from that. Sorry, you might have lost, have you lost the video? Presentation, sorry.
Yeah, down.
Okay. Okay, sorry about that. So this is the second thing that I spoke about, that if, would you be interested in doing, or is there any indication of doing any imaging to look for any perforators? So this is one of the series that has been published in 2011, and they looked at 123 cases who were undergoing free fibula transfer, and looked at how well you can pick up subcutaneous perforator by doing any imaging. What they found was that there was literally almost zero correlation between MRA finding of the number of perforators and the per-operative number of perforators that they could find. And, it was significant. You can look at the P level as well. So that just shows to suggest that, you may like to use Doppler, but however, your per-operative assessment of the perforators especially cannot be, superseded or cannot be replaced by doing any imaging in these areas. Now coming to the donor site, recipient site imaging, whether it is worth doing any imaging of the recipient site or not. So the area that you would be concerned about is to have a look at the carotids, whether your carotids are in a condition in which you can plug your vessels into. So this is again a series that has been published in 2008, in which they showed that, they looked at 44 cases to see how much external carotid is involved. And if external carotid is involved, would that have any correlation with flap failure? So what they found was that even if the general carotids are involved, the common carotid and the internal carotids are involved, the incidence of external carotid involvement is much less as compared to the other carotid trunk. But there was no correlation between carotid artery stenosis and flap failure. So yes, if you want to screen for external carotid, you can do that. But whether that is going to make any difference in terms of whether you're going to use a free flap or not, there is no definite evidence in the literature at the moment. Having said that, in all the cases for upper GI or head and neck reconstruction, these patients will be having CT imaging, MR imaging, and it is, quite pertinent that you can have a look at the carotids, how much the carotids are involved, and you can base your judgment of which side you want to go for to choose as the recipient vessels. Our protocol for the recipient site is that we do contrast CT staging for all these patients. And as I said, that you can have a look at the carotids by doing that. If we feel that the carotid is involved and that might require some input with our vascular surgery colleagues who may need to replace the carotids, then we'll ask our interventional radiologist to do a carotid balloon occlusion test to see if the patient can sustain the closure of carotid in order to reconstruct the carotid. If that is not possible, so in those cases, we might consider that, maybe we would like to consider going for a pedicle flap instead of a free flap if we can't have a good recipient vessel in there. Similarly, in cases who've got past history of neck dissection, whether the IJV has been preserved or not, whether patient had previous radiotherapy, previous free flaps have been used, where they have been plugged into. So all of these things are a consideration in choosing the recipient site, but there is no evidence that you need to do any specific imaging other than what you will be normally doing for the assessment of head and neck cases in any case. Okay, so we're coming to the next part of it. Are pedicle flaps safer or not if we come to the choosing whether we are going to go for a free flap or a pedicle flap? Sorry, I'm some trouble with sharing the screen. Historically, there have been large series of using pedicle flap, especially pec major flap, for various reconstructions in the head and neck region. And the survival rates of pedicle flap has been shown to be almost 100%. But when you come to the series of free flaps, and as Jonathan mentioned, our nationally published data as well, that the free flap survival rates are more than 95% in most of the units who are doing regular free flap reconstruction. So there is not a significant difference in terms of flap failure rates, whether you come to pedicle flap or a free flap. You can say that early post-op monitoring in the patients is relatively less intense as compared to pedicle flaps, in pedicle flaps as compared to free flaps. And there can be a potential that the take-back rates are less frequent as compared to free flap. But then again, is this good enough a reason for you to go for a pedicle flap or not? Similarly, when we talk about donor site morbidity of choosing a pedicle flap or a free flap, there are lots of publications recommending that probably free flaps would have less of a morbidity as compared to choosing a regional free flap, a regional pedicle flap like pec major or LD. But if you look at the published literature, the morbidity is almost similar, although it's more of a functional morbidity in pedicle flaps. But about 10 to 15% donor site morbidity is seen in all of these cases. So we can say that the pedicle flaps as well as free flaps are similarly safe or unsafe for various situations. But if you think about the main aim of head and neck reconstruction is to try to restore the functional aspects of, or restore the function of whatever part of the head and neck region has been taken out. If you look at the literature, you see that the length of the stay of the patient stay is higher when we talk about pharyngeal reconstruction. The feeding tube dependency is higher in pedicle flaps, and there are other evidence that there is a higher incidence of fistula rates and poor speech outcomes if we come to the pedicle flaps. So you can say that the survival of the pedicle flaps is possibly marginally better than the free flaps. But if the complication rates and the long-term morbidity related to the pedicle flaps is more, then would you still consider the pedicle flaps to be safer or not? So that is the question I'm going to leave you with. Okay, thank you very much. I think that's the end of our session.
Thank you very much, Sarmad. I'm just gonna, we did a poll while you were talking. I'm just gonna share it. And there was one question that Walter received, I think.
Yeah, it's from Nina Huttinger. And it's a practical question on how many cases you do per year on head and neck.
So in our unit across both specialties, we're probably doing in the region of 70 free flaps a year. But one of the reasons that that's dipped a little bit is because we've had some problems with recruiting the oncological surgeons to do the resective work for us. But we, between Sarmad and myself, in terms of pharyngeal reconstruction, it's probably about 25 a year, plus another 10 or so cases of temporal bone and facial reconstruction, and then somewhere in the region of 40 to 50 oral cavity reconstructions a year. But the numbers are growing quite rapidly. So we anticipate we'll be at around about 100 free flaps a year within the next couple of years.
Thank you very much. Can you tell something about the research you've done? Because it's a very impressive number you've collected nationwide.
Yeah, it wasn't 11,500 in our unit. We haven't been that busy. So actually the data was, it was collected by one of the teams in London. I can't take credit for it. But what they did is they looked at hospital episode statistics, which is some data that's gathered nationally from every single hospital. And they were able to use the different codes that have to be put into this HES data to extract from that what flaps were done for what region of the head and neck, whether they were taken back to theatre or not. So the data isn't 100% precise, but to be able to get data on 12,000 flaps is really impressive. It's very powerful because of the size of the data. And one of the things that we really like about it is that isn't the units that have chosen to show off their work. That's everybody having the data extracted from their unit, whether they wanted it extracted or not. So it's a very honest appraisal of where head and neck reconstruction in the UK is at.
Yeah.
It's also representative of various units where the reconstruction is being done by the max spec surgeons. Some of the reconstruction is being done by the plastic surgeons. So all this data is a combination of various specialties doing the reconstructive work together.